So good morning and welcome everyone. I'm Ankit Sanghvi. I'm the Executive Director at Texas Health Institute and excited to welcome you to today's webinar entitled COVID-19 in Texas, an opportunity to improve the oral health system in Texas. First things first, before I kick off our today's discussion, wanted to share a few housekeeping notes and announcements. Today's webinar is being recorded and the link to the recording will be available on the Texas Health Institute COVID-19 um, page on our website early next week. However, the slides from today's presentation will be available on our website immediately after this webinar. We are throughout this webinar, please utilize the Q&A option at the bottom of your screen to send any questions that you have for either an individual panelist or it's open-ended. You can send it throughout the webinar presentation. However, we have planned for a significant amount of time towards the end of or the latter part of this webinar to answer any questions that the attendees may have. And lastly, at any given point of time, if you have any technical issues or difficulties during today's webinar, please feel free to use the chat box window. Again, use the chat box option for any technical difficulties or concerns that you have. Throughout today's webinar, one of our convening team staff members will be more than happy to address that concern for you. However, for any questions that you have regarding today's presentation and would want one of the panelists to respond to, please utilize the Q&A option again. You can find this at the bottom of your screen. Next slide, please. To just provide a quick background on Texas Health Institute and why today's webinar, we are an independent, nonpartisan, nonprofit public health institute in the state of Texas, and with a mission to advance the health of all. In a nutshell, we describe the value proposition of our work lies in our three-pronged strategy of producing evidence and ideas, complementing that and really bringing in the piece of sense making is our second strategy of translating and sharing insights for action. And then ultimately, again, as a nonpartisan institute, fundamental to our role is the strategy of advancing collaborative action. So keeping in mind our role as a public health institute and also the responsibility that we have to play as part of being a component of this public health and health ecosystem, COVID-19, of course, has laid bare the systemic inefficiencies as well as the vulnerability of our public health and health ecosystem. Early on this year in March, a few weeks in March after the Governor Abbott had announced the pandemic as an emergency declaration for the state of Texas, we announced our response or shared our response for the pandemic and an all hands on deck approach. This webinar series is an important part of that effort. However, our efforts and response doesn't stop here. We seek to continue to partner and engage with each one of you and our communities at large in our journey moving forward as the state and our communities continue to shape and inform their response and recovery efforts. Next slide, please. Again, as I said, that this webinar is part of a five-part series that we announced last month. And over the last 5 weeks, we have had the honor of releasing 5 issue briefs on different topics, beginning with health equity, then looking at our physical health and primary care, then shedding the light on the behavioral health needs and response during the pandemic. Last week, we announced and had a webinar on transgender and gender diverse experiences during a pandemic. And then today, and last but definitely not the least, we have the brief that we released earlier this week on oral health and today's webinar. And it's an honor and pleasure for me to invite and have the company of 2 leading experts, both in our state and the national oral health landscape, Dr. Rhonda Stokely, Dental Director with the Texas Department of State Health Services, and Dr. Sean Boynes, Vice President for Health Improvement at the DentaQuest Partnership for Oral Health Advancement, to join us for today's webinar and discussion. Before I transition to Dr. Stokely and Dr. Boynes, I would love to take a few minutes to provide a quick background on why oral health is important during the pandemic or in planning the pandemic's response and recovery efforts across our state. But more importantly, why do we frame it as an opportunity? And what is an approach we should take to leverage this opportunity that the pandemic has offered us as far as improving the oral health system in Texas is concerned? So as we thought about developing the brief and even approaching today's discussion, the idea was that oral health or reforming our oral health system has kind of come as a necessity, or the understanding is clear and the evidence is out there that it is a necessity given the clear linkage that oral health has with systemic health. And more importantly, what we have seen as a constant theme across the state as well as the country is that the pandemic has impacted or disproportionately impacted the same communities who suffer from health or poor oral health as well as other chronic diseases and conditions, and what we also refer to as factors being defined as social determinants of health. And as we look at improving health or protecting these communities from the pandemic, eh, oral health provides an important opportunity, but also is an outcome that needs to be controlled as well as addressed as part of really ensuring that long-term outcomes for these populations and really for all of us move in the positive direction, and we are able to move systematically move the needle on health outcomes for all. Concurrently, what we have also looked at is that in the last couple of years or a decade, I would say, that there has been in policy inertia as far as reform of our oral health system is concerned. And the numbers has started trickling in early part of the pandemic, and even what we continue to see, we actually offer some of those data points within this brief, that the oral health system became, or the infrastructure and capacity was vulnerable in the early phases of the pandemic. While it has tried to rebound to normalcy, we still see continued challenges. And without clear certainty on what this pandemic is going to translate into as far as a long-term impact, early estimates and numbers that we have seen right now, it's fair to assume that it's going to have some sort of negative impact on the state's oral health capacity and infrastructure as we look at it in the post-pandemic scenario. The opportunity piece really comes with the idea that the pandemic has really led to opportunities in the larger public health and health ecosystem as far as system transformation efforts are concerned. And what we have seen is primary care as well as behavioral health systems have positively responded. We also shed some light on some of this transformation efforts in the two briefs we have released in the last few weeks on concurrent efforts within the primary care and in the health systems perspective, and oral health as an opportunity to leverage this interventions and efforts to advance transformation within the oral health rather than working in isolation. So again, we hope that this helps set the context for the way we approach developing this brief and the recommendation we have to offer. But just for a quick overview, the brief again, you have it available on the Texas Health Institute COVID-19 page on our website. And the purpose of developing this webinar or even the brief that we released was to identify and analyze COVID-19 impact on Texas oral health needs and capacity. In the process, we want to highlight the linkage that we seek to create more awareness for, but more importantly, that is fundamental to achieving health improvement for all populations. And in the process of doing so, we wanted to provide some system level recommendations to improve the oral health system in Texas and how we can truly leverage this opportunity for long-term change. As we developed this webinar, we identified three key findings or findings around three key themes. Even before pandemic, this is not something that's an outcome of the pandemic, but prior to the pandemic, we have all been aware, we have all come across data that oral health is disproportionately impacting our minority populations, whether it's by race, ethnicity, education level, or income. And while state-specific data for the state of Texas on oral health burden and outcomes as far as demographics or even for population at large was not available, CDC has collected some data, and one of the briefs that they had released earlier this year, I believe in June, they did come out with the statistics that non-Hispanic Blacks and Hispanics and American Indians and Alaska Natives have the poorest oral health of any racial and ethnic groups in the United States. And this were basically the same population groups that were experiencing worse health outcomes or worse prevalence and mortality as far as COVID-19 is concerned. While the again, as I mentioned, that the data was not available or is not available for the state of Texas as far as COVID-19 oral health and the outcome in different demographics, knowing where we were as a state and the experiences in the state prior to the pandemic, it's safe to assume that we are going to experience a worsening burden as far as growing disparities is concerned between the population at large and the minority populations in our state. The second takeaway, and as I mentioned in the overview slide of setting the context, is the pandemic does um, lead to a point where we are going to see a negative impact, or it's safe to assume that there is going to be a negative impact on our state's oral health capacity and infrastructure. I think the story is very visible within these two graphs where we compare the state of Texas and US dental practices. We have to give a shout out and recognize the American Dental Association's Health Policy Institute for their effort in starting a survey going back early March and has been continuing to date. In fact, the data that's available in our brief and on this slide is limited to September 21st. And as of yesterday, I do know that they released another week of survey data. What we have seen is that, of course, for the first 4 weeks of the pandemic, given the recommendations both by ADA, Texas Dental Association, the Department of State Health Services, and several other state and national organizations, that dental practices did end up closing and were only open to seeing emergency patients only. And we can definitely see that within the first 5 weeks, it was to a point where virtually or in a way that most of the dental practices in the state of Texas had closed down, and it would definitely impact the financial sustainability of these practices. Another important point to note is, and again that we mentioned in this report, is that even in the first 3 weeks of the pandemic or leading until the end of April, when we looked at unemployment claims, both in the state of Texas and nationally, dental clinics or professionals working for dental practices or dental clinical settings ended up being one of the key or largest groups of filing unemployment claims, which speaks to the vulnerability of the system. And while we must recognize the resilience of the oral health system in the way they have rebounded to being in the pre-COVID era and continuing to serve the health needs of our communities, we must not ignore the story, what we had experienced within the first 2 months. More so, it's very clear for the impact it would have on our safety net system. And as we look at the need to strengthen and sustain our oral health infrastructure through and beyond the pandemic, there needs to be a specific focus on the safety net. And we say so for some of the points we have to offer. So prior to the pandemic, when we looked at where do Texas's indigent care population receive their oral health, for the kids, several school-based programs working with the state or local health departments or through health systems or philanthropic organizations have been serving the needs, but most of these programs were in a school-based setting. The school closures as a result of controlling or in response to the pandemic has really taken away that point of care from these kids. And oral health is the most chronic disease prevalent in children, in young children and adolescents. More importantly, Texas continues to be one of the very few states in the country that does not have a Medicaid dental benefit for our adult population. So you are on Medicaid until you turn 21, and then you're off the cliff. And what the pandemic has done has already expanded the widening burden. So prior to the pandemic, we had 20% of our adult population in the state of Texas that was uninsured, expected to grow at least to 26% in the next couple of years. And what we have seen is that with each one of or each adult in Texas that does not have health insurance, there are 2 adults that do not have that are uninsured and do not have dental insurance or a coverage. So the same number of uninsured burden for health insurance is going to be much more worse for growing uninsured burden for oral health or adults not having oral health uh, coverage in Texas as we emerge through the pandemic. So addressing that is going to be a critical point. Concurrently, what we have also seen as a result of not having an adult medical dental benefit is that we have seen increased emergency department use and preventable deaths. As we look at smart public policy and cost savings, we need to look at the impact, the economic impact that the lack of a dental benefit would have on the state's healthcare resources. And what we do not want to do is overburden our emergency departments, as they already continue to be at the forefront of fighting and addressing the rising cases of COVID-19 in our state. What we have also experienced is that the safety net providers have had a challenge as far as, again, going back to a policy inertia within oral health reform for oral health reform in our state over the last decade or so, is that we have not seen an increase in our Medicaid reimbursement rates. And that continues to be one of the key barriers in not having enough providers to be able to serve Medicaid patients. So what we have seen is that there have been even prior to the pandemic, uh, the oral health safety net system was already vulnerable and facing challenges. And given the impact of pandemic on the oral health burden, but also the health disease burden, is going to further complicate that story. And we will need to protect it if we do not want to see more patients approaching or visiting the emergency department, and even potentially putting their lives at risk for not being able to access dental care when they need it. The last finding, and which I think is fundamental, we saw it as a positive, that the pandemic really has given us an opportunity to think about the oral health team as part of the health team. And we have come across stories both within our state as well as across the country within the public health departments or the federally qualified health centers, where the oral health team has been at the forefront, collaborating and coordinating with the primary care and behavioral health teams in addressing the needs of our population and delivering health. The pace of the integration has been commendable, and with that, we have also seen opportunities for growing recognition of the role oral health professionals can play in person and community-centered care design. Um, Moreover, with the pandemic, and we talk about the same group of populations experiencing worse health and oral health outcomes, it's important for the oral health team to address or think about their role in addressing social determinants of health if long-term health outcomes need to be improved as far as the burden of our state's oral health needs is concerned. And again, going back to the initial point of coordination and collaboration, that with health as an outcome and as part of our pursuit, opportunities and needs lie for oral health team to be partnering or collaborating with the primary care and behavioral health team members as part of delivering care for our communities. And with that, we wanted to provide in the last few slides an overview of the framework that we have offered as far as the recommendation is concerned. Again, thinking about it from a systems lens and prioritizing uh, a person and community centered approach, that all health needs to be delivered with a health equity lens. But concurrently, we need to be thinking about and advancing care transformation and collaboration efforts. Look at financing of our current oral health needs and systems as of today, but also how they need to be transformed in a way to facilitate care transformation and collaboration for a person in community-centered setting and approach. We definitely need to address the policy inertia as far as our oral health systems reform is concerned, and that means looking at the Medicaid dental benefit for adults as well as Medicaid reimbursement rates, but also the role of Tele Dentistry and in a way of prevention or patient coordination and communication. And one first and or I would say foremost, or in a way to validate any transformation efforts, is the need for continuous quality improvement and ongoing evaluation. And even in the process of developing this brief, as I mentioned, that we didn't really come across any data for the state of Texas as far as the oral health disease burden is concerned specific to the pandemic. And I think that needs to be addressed, and we have tried to offer some thoughts in a way that can help us fill that gap and truly track the progress of the transformation that we may be able to see and pursue from here on. So with that, next slide provides, again, a breakdown of those recommendations, and I believe we are ready to transition to Dr. Stokely as our first panelist, and to offer a perspective from the State Health Department on what their approach has been during the pandemic, best practices or opportunities as a result of the pandemic, and to see and hear from thoughts that she has to offer as far as our ongoing response and recovery efforts in the state of Texas is concerned. And with that, Dr. Stokely, transition to you. Thank you.
Great, thank you. It's good to be here this morning, and thank you to Ankit and the Texas Health Institute for the opportunity to speak to you today. So as Ankit said, I will be talking to you about the Oral Health Improvement Program, which is our state's public health program, and how we've been impacted by COVID-19. So we are located in the Texas Department of State Health Services within the Community Health Improvement Division. Medicaid is the Texas Health Steps program is over in the Health and Human Services Commission. So I don't work with Medicaid directly. I strictly do the public health aspect. We have three main activities, which are Smiles in Schools, Smiles for Moms and Babies, and Oral Health by the Numbers. A little bit of background on how children are faring in the state. We focus on children. Our priority populations are pregnant women, infants, and children. And you can see here from surveillance that our regional dental teams conducted in the past few years. We've got the breakdown for kindergarten and for third graders of the percent of public school children in Texas by types of dental coverage. And it's pretty similar between the two grades. So over 40% are on public dental coverage, and about 20% or so have no dental coverage, and then there's over 30 that have private dental coverage. And of course, keep in mind with that private dental coverage, that is pre-COVID, and so we can assume that might be higher because now parents have lost jobs and therefore the coverage that they were able to provide for their children. Next slide. With our surveillance, one of the most important things that we evaluate is Carrie's experience. And what Carrie's experience is the history of tooth decay for that child. So when we screen a child, we're looking to see, do they have a filling on any tooth or do they have untreated decay? Either way, that combines to be the Carrie's experience for that child, because whether it's treated now when we see them or not, that child has had experience with tooth decay. And for kindergartners, it was almost 53% have experienced tooth decay by the time they're in kindergarten, and that increased significantly to a little over 67% by the time they're in third grade. Neither of these is good. We are far above the standards for Healthy People 2020 and also the standard for Healthy People 2030, excuse me. For 2030, it is 42.9%, I believe. And so you can see we're quite above that. Ankit, and a nod to the brief by Texas Health Institute that really focused on the Hispanic population and disparities there, we learned that compared to white non-Hispanic children, those identified as Hispanic were 60% more likely to have a history of tooth decay, regardless of the grade that we evaluated. So our Smiles in Schools program is statewide. We have 5 regional dental teams. Each dental team has a dentist and a dental hygienist. They're based in Lubbock, Tyler, Houston, San Antonio, and El Paso. And they travel all over the state. They have very large regions that they cover, and they manage to cover quite a bit of it over the course of a year. They have portable dental equipment and can set up in any space that they're allowed. Sometimes it's a gym, sometimes it's a classroom, it could be the cafeteria. They conduct limited oral evaluations, apply fluoride varnish, place dental sealants, and also provide oral health education. We've got a photo here of one of our regional dentists, Dr. Anita Albert, and I put the disclaimer that this is a pre-COVID photo because I don't want anyone to think that we have Dr. Albert currently smiling maskless down at a student. So pre-COVID photo. And this is kind of what one of our setups can look like. In fiscal year 19, which pretty closely approximates the school year, our fiscal year begins in September and runs through August. In fiscal year 19, we screened over 10,000 children, applied over 10,000 fluoride varnishes, sealed almost 500 children's teeth at a total value of $1.17 million. There's a little asterisk there next to the sealant numbers because that was one of our big surveillance years. And so our primary focus those years is not as much sealant as it is conducting the proper amount of surveillance so that we can have a representative sample. Fiscal year 20 has a big asterisk because our year ground to a halt in mid-March. So we were able to operate about 54% of our fiscal year. In that time, we conducted over 9,700 limited evaluations, applied over 9,900 varnishes, sealed almost 750 kids at a value of $1.19 million. And so we were on track, of course, to see a lot more kids than we were able to because, again, everything ground to a halt at that time. So what did we do from March until now? A lot of our dental staff have been redirected to the COVID-19 response, especially our regional dental teams. Some have been working on contact tracing. One took over responsibilities as the safety officer for their building because the safety officer was recruited into some of the other COVID-19 response. And even one of our staff worked with epidemiologists on the slides that you could see if you go to the DSHS website, the COVID-19 dashboard. They contributed to those efforts. And so that's what they've been doing a lot of this time since. We convened the state's school-based sealant programs. We had a meeting virtually to discuss COVID-19 and how they foresaw this impacting them, and just the challenges of acquiring the right PPE, and you know, all the different things that we've had to take into consideration now. We'll probably meet again sometime soon to see how it's gone for them now that people are kind of getting back into operations. We are a member of the planning committee for the Texas Oral Health Conference. That was supposed to be in person in Georgetown back in July, and we were able to pivot over to a virtual format, which actually turned out to be a really positive thing. We made it a virtual conference. We did not charge attendance for it, and I think it opened up our world of oral health to a lot of people that may not have been exposed to it otherwise. We had a lot of nurses, we had medical staff, we had a lot of community health workers. And so I don't know that we would have had all of those people in attendance if it had required the travel to go in person. So a blessing in disguise there for the Texas Oral Health Conference, I believe. So for Smiles in Schools this year, how will it be different? The biggest thing is we're going to see fewer children. We're proceeding very slowly towards getting back into schools. As you can imagine, schools are pretty overwhelmed right now. They've been opening to in-person learning at varying schedules. Some have already had to close back down because of outbreaks in their schools. And school nurses, in addition to the massive amount of work they had to do already being a school nurse, now they're responsible for COVID work as well, screening children, contacting parents if the child has something that remotely resembles COVID-19. And so their work responsibilities have increased greatly. And so we're trying to figure out, they're our primary partner for visiting schools. And so, like I said, we've just been taking it very slowly and being very cautious. Clinical protocols, of course, have been adjusted to match CDC and the State Board of Dental Examiners, which for us was not that big of a change from what we do traditionally because we don't really generate a lot of aerosols. There is the possibility for aerosol generation with certain types of sealants, but not with others. So not a really big change in that sense, other than just, you know, if there are aerosols, having the N95 respirator, otherwise having face shields and surgical masks, and making sure that we have proper spacing so that children aren't huddled up in a line like perhaps they would have been. Our surveillance component of our program, Oral Health by the Numbers, has fortunately, the surveillance that we conduct directly has not been impacted by COVID-19. We conducted our oral health basic screening survey of kindergartners and third graders just a couple of years ago, and we only conduct that every 5 years. So thankfully, we're not impacted. But I have talked with other states that have already spent a lot of time and money and preparation thinking that they were going to be conducting that very important surveillance this year, only to have it upended because of school closures and COVID-19. We don't know yet. I'm not sure how it's going to affect other sources of surveillance data for us. We get oral health data from a number of other sources, one of which is the Youth Risk Behaviors Surveillance System, which is a survey given to children in school. I'm not sure how that's going to be impacted. I don't believe the SPAN survey, which is the School Physical Activity and Nutrition Survey that's conducted in Texas, I'm not sure that that's going to be conducted this year. So we may have less data to go on from other sources. Smiles for Moms and Babies is our program that focuses on getting pregnant women to see the dentist and getting baby to the dentist by age 1. Our biggest challenge with that is just making the move over to virtual. We had been having wonderful in-person educational trainings for parent educators and home visitors, providing them with oral health resources and talking about oral health in a way that they would feel confident bringing it up to their clients. So those we're working on moving those to an online format. And the same with our second phase of this program, which was to really roll out provider training for prenatal providers and dental providers. Those are going to be online now rather than in person. So again, I am not involved with health steps in Medicaid, but I did run across this information and wanted to share it with you. This is some data released from CMS, the Center for Medicare and Medicaid Services. We're going to look at the graph here on the left. From March through May, based on preliminary data, so it's subject to change, but during that time frame, 69% fewer dental services were conducted in the U.S. compared to the same time frame back in 2019. And this graph here on the left, that little teal colored line, is Texas. We made it onto this graph because we were one of the 5 states that had the highest increase in services as of May 2020. And so that coincides with the time that we were allowed to go back to comprehensive dental services in Texas. I just want to share that with you. I don't have any Texas-specific data, but I did talk with our Medicaid dental director, Dr. Marguerite Lacabou, and she said that the amount of services provided right now is pretty well back to its normal rate. And so that's it for me, just a little overview of how we're doing and how we're coping. And when we get to the end, I'll be happy to answer any questions that you have. Thank you.
Thank you so much, Dr. Stokely. That was very informative, and we'll definitely open this up for questions. But now it's my pleasure to ask and invite Dr. Sean Boynes, again, Vice President for Health Improvement at the DentaQuest Partnership for Oral Health Advancement, to bring a national perspective and really speak about some of the system transformation efforts that DentaQuest has been leading across here in Texas, but also across the country. Thank you, sir.
Thank you very much, and thanks to the Texas Health Institute for having me, and to my colleagues for allowing me to represent my little neck of the woods and my little piece alongside of you. So today I'm really going to discuss 2 things. We have a provider survey that came out last week that'll give a national landscape and show how Texas is comparing from those self-reports, and also delve a little bit into what's going on in the community health center world as well. So it is a COVID-19 impacted world. Whether you're in Texas, North Dakota, Maine, or anywhere else, you have felt the impact of COVID-19, and dentists are no exception. And so really what we've tried to do, the ADA Health Policy Institute has also tried to do, is really make sure there's a communication line and an understanding of what's going on and how dentists and dental care teams and oral health care teams are reacting to this new world we live in. So this is information from August 17th to September 1st, a provider survey that went out to Medicaid or DentaQuest participating providers. If you look, we conducted this through August. There was questions on attitudes and knowledge. We about a 13% response rate, over 2,700, and there were 431 providers in Texas. When we look at the providers in Texas, the majority of them are in private, what we consider traditional private practice, or community-based dentists. There's less representation from dental service organizations or DSOs. So whenever I give you the results, you'll see that nationally, it looks like Texas is lagging behind. We think that if there was more DSO providers participating, it would be a little bit closer to the normal. And I echo Dr. Stokely's piece of looking at where capacity is at and saying it is close to where 2019 was at right around this time. So Texas is recovering, and we did see that in the provider survey for Texans, which was 97% of providers were open for all services, but there were a few struggles. 75% reported significant reductions in patient volumes and revenue, as compared to about 65% nationally. 52% are seeing fewer new patients than pre-COVID, as compared to about 44% nationally. And this was an interesting number that we wanted to look at, because we were seeing reports of some claims data where that comprehensive oral evaluation, that 0150 code that goes in, which kind of signifies either a new patient or the first time you've done a comprehensive in 3 years, has declined somewhat. So we are going to keep a closer look and watch on that particular number, making sure that new patients are coming into the offices and diseases being treated. 61% are seeing more patients without commercial dental insurance due to job loss, as compared to 52% nationally. That number, I don't think will be too much, is not too much affected by the provider mix that we have in this survey. That does seem to be something that has been trending up nationally over our last 2 surveys. Of course, if you want to get more information on this, you can always go to the DentaQuest partnership.org, which is our website. It's available there. You can link right to it and find a little bit more information and exactly how we were able to get the survey completed. Next slide, please. One of the other things that we looked at was teledentistry. We know that in Texas, teledentistry is not a format that is being currently utilized within the state. One of the pieces that we kind of looked at was, well, how confident would people in Texas, dentists in Texas, be if we did it? And then looked a little bit more at some of the rural areas, because we do find that there may be some benefit in Texas for being able to bring teledentistry in. So right now, 1 in 5 of the Texas providers are confident they can utilize teledentistry and see it as a long-term change agent. Nationally, that's 3 in 10 providers are currently seeing patients via telehealth, so it's around 30% of providers are doing that. 77% of providers using teledentistry platforms expect the volume of encounters to increase or stay the same over the next year. And rural providers are more likely than those in urban and suburban environments to use telehealth to triage patients, prioritize care, prescribe needed medications, and visually examine the teeth and the mouth. And so the need for teledentistry is there, and we're seeing a lot of movement within the rural environment. Next slide. There really are 3 components that we've been observing that are being utilized within teledentistry. Component 1 is that synchronous urgent visit, which is probably the one that more people are aware of these days. This is really what came out during the COVID-19 crisis and the pandemic. And really what was found with some of the early data so far is that 40% of urgent telehealth patients did not need to be seen in person for an emergency treatment. So 40% of those who had called in for telehealth could be treated just over the same interface of how we're working. I think I heard one provider that gave a great anecdote of somebody having a popcorn kernel stuck in their gingival sulcus, and they were able to take care of that through telehealth. So, there are ways that we can provide care outside of just the traditional brick and mortar setting. The other thing that we found, we looked at emergencies in the prior couple of years with our IBM Watson data, found 65% of the procedures that are performed in office emergency visits traditionally really only involve diagnostics and sometimes not even a radiograph, with less than 1/3 needing restorations or tooth removal. So already in our system was a visit, an emergency visit, in which definitive treatment was usually followed up later or there was none. So you can see that there's also a window for that synchronous urgent visit. Component 2, synchronous prevention visit. This is one that we're seeing kind of really move more forward in the holistic care experience, which is using synchronous prevention visits to talk about caries risk assessment, tobacco cessation counseling, nutritional counseling. And we're seeing a lot of like holistic care experience where you may have a integrated interprofessional health visit. And a lot of these are being augmented by virtual first or telehealth health plans. And then component 3 is asynchronous visit, which was probably the most common and popular prior to COVID, which is you have some, usually an advanced practice practitioner, like an advanced practice hygienist, out in the field doing evaluations and oral hygiene visits, loading the information, pictures, radiographs up into the cloud. And that's viewed by a dentist somewhere else, sometimes at some other time, in order to develop treatment plans and course of treatment. We have some early data that really came out of a rural initiative looking at really 2 parameters. The first is if you do a caries risk assessment with anticipatory guidance and counseling and coaching, is there some sort of impact that can happen? And that's what you see in what's figure 4 at the top. And this publication will be out October 26th. So if you go to our website on October 26th, you'll be able to see this particular findings. But what we found is the individuals that had that were less likely to need emergency dental visit, less likely to need surgical intervention, more likely to need preventive procedure, cost less, $883 to $630. The figure 7 that you see below is looking at asynchronous visits. This is also a rural integrated clinic that's in a value-based care design. They had all other dental treatment visits were 593. Those that had the telehealth visit and the intervention was about 483. So, I ended on the money, and the other thing is always remember to follow the money. We talked about Tele Dentistry. One of the things that we're finding is that is stabilizing and continuing to be something of a tool for prevention. And a lot of the business models that are associated with managed care, accountable care, value-based care, or somewhere out of that traditional fee-for-service mechanism. And so the other big piece of movement we're seeing nationally is the exploration of value-based care designs or alternative payment models. What I'm going to share with you are some of the findings from a white paper that the DentaQuest Partnership put out with our partners, the National Association of Community Health Centers, or NAC, really looking at a lot of the parameters that demonstrates that FQHCs can be the oral health value-based leaders based on the system and operations that they have. So we evaluated a couple of different things with NAC. And one of the places that we wanted to look at, what you see on the left side is NAC's Value Transformation Framework, which is a framework to help community health centers make the transformation over to a value-based care design. And what we did with NAC is try to find some of those areas where oral health fits in and can help the transformation process. And one place is targeted interventions, especially with diabetes. We know that there's a lot of connections and linkage with diabetes and oral disease. And so one of the places we looked is to determine what is the impact that FQHCs are having here that would line them up for a better value-based design. And really what we found was dental services help FQHCs reduce the burden of chronic disease. We looked at the UDS report, which was about 630 health centers that are involved. We found if 70% of the patients had dental care, the proportion of diabetic patients with uncontrolled or poorly controlled diabetes would decrease from about 34 to 24%. If you're counting at home, that means for every 1% increase in a patient that is seen, a diabetic patient that is seen for oral health care, that's a 0.2% reduction in the overall spending that is related to uncontrolled diabetes. As you can see on the right-hand side, those are substantial costs. So controlled diabetic is about $4,800 compared to $9,600 and $15,000. The other thing I'll add here is we're not saying that if you have periodontal disease, the subsequent is that you're going to get, if you have periodontal disease treated and you're a diabetic, the subsequent result is that you're going to be healthier and you're going to reduce cost. It appears, and this is what we kind of work with NAC on, is it's the holistic care experience that's allowing for these improvements. It's a structure that sits in place that allows for the patient to be treated holistically as opposed to fragmented, and they does result in more control of the disease process. That's it. I'll turn it back over to Ankit.
Awesome. Thank you again, Dr. Boynes, for sharing your expertise, but also work that the NetQuest partnership has been leading across the country. And we, as promised, we have planned time for Q&A. So for all participants on today's webinar, please feel free to use the Q&A option on the bottom of your screen. And as I announced, we already have the first question, Dr. Boynes, for you. Regarding diabetic patients, do you have any thoughts on those who avoid diabetes completely due to access to dental care? Dr. Boynes, you might have to unmute yourself. Sorry.
Yeah, can you, sorry, I was trying to find the question. Are they asking they avoid diabetes or avoid diabetic care? Sorry.
So I'll read it out and probably paraphrase it. So regarding diabetic patients, do you have any thoughts on those who avoid diabetes completely due to access to dental care? So if I understand it correctly, and Dennis Pereira has asked this question, so Dennis, you may want to retype it if I have framed it incorrectly for Dr. Boynes to answer. But I believe the idea is that they don't develop diabetes at all. So the idea is the preventive benefit of having routine access to dental care. Could that play a role in avoiding diabetes?
I don't know of any research that I could make that claim. I think that's the hope of many. I'm not sure that I have any research or any way to back that up. I think what we're seeing here is that when there is a holistic care apparatus, or that you have the recognition that if you have a caries disease, if you have caries diseases or you have periodontal diseases, you have a systemic disease, right? The inflammation mediators, the interleukins, the tumor necrosis factors fire off the same with an oral disease as it does for a litany of other systemic diseases. That it's the concomitant issue of having two diseases that are really wrecking your body. And that if you're not actually treating both diseases, you're kind of behind the eight ball. And that seems to be where the science is leading us, which is why we're seeing it much more as health services research as opposed to randomized controlled trials or things like that, because it's the structure of the system that is helping make people healthier. We don't know where the limitations to that are, but I think we get there quicker than the second piece, which is the cause and effect. So I think I answered that right based on the description you gave me. But if not, I'm happy to talk more or go offline.
No, thank you, Sean. I think that's how I've understood the question, and I would just concur with your initial statement that while there is no evidence at this point of time that even I would be aware of, Dr. Stokely, I would invite you that would support the claim. The hope is and the understanding so far that we have is that dental access to routine dental care does have a positive benefit or an outcome as far as chronic disease outcomes are concerned. So
I am not aware of any research. The general consensus is that there are definite linkages between diabetes and poor oral health, but not causation. So we can't point to someone who gets routine dental care and saying, that's why they didn't get diabetes.
Well said. Thank you, Dr. Stokely. We have time for other questions as well. And as we are still waiting for more questions, I might take this opportunity to ask a question that I have for both of you after hearing your presentation. So if you want to go, so I'll open this as a question and we'll leave to you on who wants to go first. So as we think about, during the pandemic, it's really the Hispanic population in Texas, Dr. Stokely, as you pointed out, has had a disproportionate burden, both not just for oral health needs, but also COVID-19 from the data that we have available so far. As we look to continue to leverage the public health infrastructure resources that we have and that the state's dental program has been leveraging, what strategies or interventions can we pursue as far as closing that disparity gap is concerned, or at least not letting it, allowing it to get worse? And then the part of the question, Dr. Points, for you would be that, as you think about approaches such as telehealth or value-based framework, how do they help bridge the disparity gap? Would love to hear your thoughts.
Dr.
That was a long question.
Defer to you. Go first.
Okay. So some of the ways to help overcome the disparities in the Hispanic population from an oral health standpoint, I think one thing is improving access. And by access, I mean, more coverage for people to get dental care, but then also to be more accessible. Typically with dental practices, we tend to have just kind of almost banker's hours, if you will. And so people that are, perhaps with lower incomes, and so this doesn't apply only to people who are Hispanic, but people who have lower incomes that are maybe working multiple jobs, they can't take off from work. A lot of people, if you don't work, you don't get paid, and you may get fired. And so being more accessible with hours outside of just kind of routine business hours, I think can go a long way. And also, I would like to see more representation of Hispanic people in dental professions. I would like to see more, have Hispanic people see more people who look like them when they go to receive dental care. And I believe our dental schools are really working on improving the representation of their student population so that it includes more people of color, not only Hispanics.
Thank you. Thank you, Dr. Stokely. Sean. Go ahead, sir.
And I look, that was fantastic. I don't think I have a whole lot more to add, at least from that perspective. I think, Anka, what you asked me is more on a financial side and how those structures can start to build. I think what we're seeing is more recognition in social terms of health and in community health assets, which is a different approach, very English NHS kind of approach where within a certain system, including the budgeted system of whatever healthcare may be, there may be community assets that are necessary. As Dr. Stokely said, transportation authorities. We, DentaQuest partnership, worked with a health system in rural Pennsylvania who took over their health or their transportation authority, set up their bus stops at all of their health sites and dentist offices within their rural structure to improve outcomes. So I think those are things that I'm seeing a lot more things being talked about, not so much at the state level where it's always been a discussion, but also at the payer level, at the funder level. How are we actually going to make a more positive impact? And Ankit, I love the tagline below you, which says healthy people, healthy communities. If you get people as healthy as you want and you put them in an unhealthy community, you're really going to have a struggle of keeping the person healthy and vice versa. And I think there's more recognition of how to move that forward. Where we're lacking is we don't have a lot of science or evaluation or analysis that looks over the lifespan at those intrinsic and extrinsic events that can happen and whether or not a system invests in transportation or childcare or improving racial discrimination aspects and policies, what is the impact that that actually has on health? And we're still struggling to have a real deep understanding of that within the oral health realm. I'd love to see that be some next steps that kind of move forward. Is what does it mean in these communities and in this way?
Excellent responses and comment. Both of you, I think you hit the nail on all of the pointers, whether it is looking at investing in the right solutions, but also Dr. Stokely, to your earlier comment that unless and until we don't internalize that change and kind of start having our dental workforce reflecting the populations that we seek to serve, the change is truly not going to be sustainable and transformative in its pursuit. So appreciate you both. While we were hearing through your responses, I think there have been a couple of questions. Again, the next one is from Dennis. And Dr. Stokely, this goes back to one of the findings as part of the worsening oral health burden during the pandemic that we have identified within the brief, but also we talk about as part of the recommendation that oral health and data to date, both in Texas as well as nationally, has proven the cost effectiveness of having an adult dental benefit and reducing ED utilization as well as preventing deaths. So as we look at that as an issue, but also a possible solution, a systemic solution, the question by Dennis is that considering your state's role, do you have any opinion or on thoughts on the cost benefit aspect of providing a dental care to Medicaid adults? He does refer or cite a recent HHSC study that reported that reduced ED visits alone would pay for a dental benefit. And I think the next question we can answer within the same vein is also around an adult Medicaid dental benefit, and how can the benefit help close the gap on disparities and disproportionate burden.
Okay. So in my position, I am not supposed to really speak for or against any sort of an advocacy sort of issue, but just speaking from what I am aware, of course, it's always less expensive to prevent something or to treat it early than to let it progress. And you would assume that with having dental benefits available, someone would be more proactively seeking care, either preventive care or addressing something as soon as they're aware that a problem has arisen. So in that sense, and certainly it's very expensive if someone seeks dental care through an emergency department, and then it also doesn't address the issue. So there's all the costs of the emergency the emergency department visit, and then they might get antibiotics or perhaps a pain medication prescription, and then they've still got to go address the dental issue because there aren't dentists in emergency departments. I mean, there could be a few exceptions to that, but in general, there aren't. Now, so in that light, it sounds like it would be a great thing. I am not sure, and I'll say this honestly, I don't know, but if there were an adult benefit to Medicaid, there would also be administrative costs associated with that. I mean, it's not just a matter of, hey, you have coverage. There's a lot that goes behind the scenes into making that happen. I don't know the cost of that, and I don't know how the cost of that would compare to the cost savings, in all honesty. But to close, yes, it's certainly better to treat something early or to prevent it altogether. That's far less expensive than to treat it when it's a big problem.
My apologies, I was on mute. Thank you, Dr. Stokely, for your response. I want to be respectful of everyone's time, but we do have two questions. So one is in response, Dr. Stokely, to your previous responses, the solutions outside of the dental care setting and the role of interventions such as a community water fluoridation in increasing access to good oral health. And then I believe the last question that we can take is by Bob Cam on and I believe that's Sean for you, that do dentists that serve FQHCs or population that FQHC serves do some of those SDOH related work as employees or independent contractors? And I believe those are the two questions that we can take. Dr. Stokely, do you want to go first? And Sean, then we'll take it from you.
Sure. So yes, community water fluoridation is a great way to prevent dental disease. It's been heavily researched for decades, and it's safe and effective when water is fluoridated at the appropriate level. So yes, that is one way outside of the traditional healthcare system to prevent dental decay.
Thank you, Dr. Stokely.
And it can be both. The overwhelming majority of the time, it's an employee that is in-house, but sometimes FQHCs may outsource their dental services, in which case it would be more of an independent contractor arrangement. But the overwhelming majority of the time is an employee.
Wonderful. Thank you. And I do think there was one additional question, Dr. Stokely, but in the interest of time, I would, Letitia, we will ensure that we will capture Dr. Stokely's response and will include that as part of our follow-up communication. And even for our other attendees who are not able to submit a question during this webinar, if you have any additional questions, please feel free to reach out to one of our team members at THI, and we'll be more than happy to get our panelists to respond to your questions, and we'll be sharing it with all attendees. Just a couple of closing remarks. Again, I want to express my appreciation and gratitude to both Dr. Stokely and Dr. Boynes for your time and expertise on today's webinar. With that, I also want to recognize the team at Texas Health Institute and helping putting the brief and this webinar together. Could not do any of this without this awesome team that we have at the Institute. We also wanted to ensure that all of our attendees are aware that this webinar and the brief was part of our 5-week series that we released September 16th or started September 16th. So please go ahead and take a moment to visit the COVID-19 page on the Texas Health Institute website, where you can download all of the webinars and briefs that we have had over the last 5 weeks, including the one on oral health that we talked about today. And last but not the least, we are in this together with each one of you as far as the response to the pandemic is concerned. So at any given point of time, you have a request, you have a question, a concern that you would like to share with us and would like THI to be involved, please feel free to reach out to me or any of our team members, or information can be found on our website. Again, we thank each one of you for doing your part in improving and advancing the health of all. And thank you again for joining us for today's webinar.